All right, everyone. So I hope you are doing okay. So we are doing today the general structure, which I like to call the master key structure, because this structure should work in 99% of the cases here. And in this structure, we'll cover data gathering for any history taking station, for any OSCE exam, and we'll cover as well management here. And your interpersonal skills will be happening all through the consultation here. So let's start the same as we do in every single case. So we start data gathering by exploring the presenting complaint. So the patient will come with a presenting complaint that can be headache, chest pain, dizziness, vomiting, any presenting complaint. Regardless of the case, you start by exploring it. And when you explore the presenting complaint, you should start with an open question first. For example, Mr. Jack, can you please tell me more about that headache? And why you start with an open question? Because you need to listen to an open answer, to the golden minute. We call it the golden minute because once you listen carefully, the patient will give you a typical clinical picture of one problem. For example, Mr. Jack, can you tell me more about that headache? Doctor, it's on my right side of the head. It is throbbing, tense headache, which makes me feel tired and I need to go to bed. Okay. And it gets worse with maybe noises or flashes of light. So what is happening here? Because you ask it an open question, the patient give you a classical history of migraine and he saved a lot of time for you. So you start with open question. Second step in presenting complaint, you follow that by exploring more in the presenting complaint. And why I do say that? Because investing more in presenting complaint, saving you time from ruling out 100 differentials. So when you invest more in presenting complaint, you confirm a one possible diagnosis. So I would still follow my open question with closed questions, maybe Socrates or Odibara. Socrates if it's pain or ache, Odibara if it is another symptom. So you complete what is missing from the story. For example, Mr. Jack, how long you have been feeling that way? Is it getting better? Is it getting worse? Is there any pattern? So you complete Socrates or Odibara after you listen to the golden minute. That is the first step in any data gathering. Second step, which I always say it's a healthy question to ask, is asking about trigger. So the patient is coming with a symptom. So ask him, Mr. Jack, you mentioned you have been feeling this headache for the last 3 months. Was there anything triggering that at all? And why trigger is a healthy question? Because it can rule out or rule in lots of differentials for you. For example, if the patient is telling you, doctor, I have been going through tough time. I'm having lab exam. I'm having a stressful lifestyle. I'm busy at work. I'm going through challenges in my life. So that can tell you it's possibly a tension headache, right? Or maybe trigger if the patient told you, doctor, it was triggered by maybe driving in the dark, flashes of light, strong noises. That can be migraine. Or maybe it's a student who has been drinking a lot of alcohol at night and came in the morning with headache. That can be hangover headache then. Or maybe someone has moved to a new place with a new heater fitted, and then he and his roommates are complaining of headaches. That can be carbon monoxide. So asking about trigger helps you to rule in, rule out lots of differentials here. And then we finish our first step, which is the presenting complaint. We finish it by asking other. What does other mean? 3 things. First thing, other symptoms, like apart from the headache, do you have any symptoms at all, Mr. Jack? He may tell you, yes, doctor, I have been feeling sick. For example, migraine is very common to present with feeling sickness as well. Okay. Or maybe he may say, doctor, I have a rash in my body, an unblanching rash. So then you think about meningitis. Okay. And what is the second other? Other symptoms of the same system. So for example, if the patient is coming with vomiting or diarrhea, in this particular step, I will cover other GIT symptoms. For example, any abdominal pain, any diarrhea, any cramps. So you cover most of your differentials by asking other symptoms of the same system. For example, if someone coming with a skin lesion or a skin lump, I will ask about other associated symptoms, other skin lumps anywhere else, or other skin symptoms, like for example, redness, discharge, itching. That will complete your data gathering. Yeah. So when you do that, your presenting complaint will be almost 99% complete, and you will have a very likely one diagnosis. Yeah. And you can invest 1 or 2 or even 3 minutes in this step, because this is what saves you time later. Then the second step in every data gathering will be asking a closed specific questions. What does it mean, closed specific questions? It does mean a question which can be answered by yes or no. So you are saving time in this one. And what you need to ask here, only 2 things. You ask about the red flag, or you ask about the main differential, not all differentials, because if you can see, we already covered the presenting complaint very well, and by covering it, we ruled out lots of differentials already. So in this step, we only try to rule out any other very similar differential to the presenting complaint. And the second thing is asking about red flags. Let me give you an example. If a pregnant lady coming in her first trimester with abdominal pain, what will be your red flag? Ectopic rupture. So this is what I mean by red flag. You ask about any dizziness at all, or do you feel dizzy? Do you feel confused, or do you feel unwell? That will be ruling out, for example, rupture. Yeah. And what else? If it's a vomiting case or GIT case, what would you worry about? You may worry about dehydration. So that would be your red flag. Yes, you can ask about dizziness or feeling thirsty, or feeding, like drinking or eating. Is she able to keep things down or not? Okay, that would be the red flag usually. And then the main differential, as I mentioned, it will be the most closest one to your presenting complaint. You do not need to rule out more than 2 or 3 differentials maximum, because you have done a good data gathering of presenting complaint already. Then the third step in every data gathering is general well-being of the patient. How was the patient doing before today? So you can put things into context. You can have some understanding of his background, of his risk to this medical problem. This is what you like to call maftosa. I do not like to call it maftosa. But if you like to call it maftosa, please call it relevant maftosa. What do I mean by that? Make it relevant to the problem. For example, if the patient is coming with candida infection, okay, or vaginal thrush, why would you ask the patient about any history of high blood pressure or any family history of diabetes? It doesn't make a lot of sense here. So always make it relevant to the story. So for example, if someone coming with cough, I will ask about any similar symptoms like that happened before. Do you have any issues with your breathing at all? Any lung issues? Any family history of lung cancer? And when I ask about lifestyle, I will specify smoking. So make it relevant to the story. If someone is coming with vomiting of blood, what will be my focus then? Do you have any medical condition related to the gut or related to the stomach, any bleeding problem, any family history of bleeding problem or bowel problems at all? And then I can ask about alcohol and lifestyle. So I hope it does make sense. You do not need to ask it as a routine question every time, because your time is precious. You need to select what is relevant, and you need to make it relevant to the story. All right, and then the fourth step, or the last 2 steps in every single case, will be psychosocial and ICE. And I would strongly recommend that you always do psychosocial and ICE in most of the cases. Why is that? Because this is why the patient is coming to visit a doctor. So think about it. Yeah, you may have headache today, right? Because you're having an exam soon. That's why you're watching this video. But did you visit your doctor for that headache? No. Why? Because of 2 reasons. You are not visiting your GP for this headache for 2 reasons. The first one, it's not affecting your life yet. So you still can attend this session or this video, right? And the second thing, you are not having a specific concern about that headache. You don't think it's a brain tumor, for example, and you're not expecting something for it. You're not expecting to have a scan for it, or maybe a strong medicine for it. That's why you didn't go to see your doctor. So let's see the opposite. Why patient come to see the GP for headache, for example? Because it started to affect his life. Maybe it started to stop him from going to work, or from enjoying his life, from going out. That's why he came to you today. What is the second reason he may be coming to visit me today? Because he thinks this can be a brain tumor. He's worried about it. And then he is hoping to have a scan for the headache. That's why he came to me today. So what is the bottom line of that? That you need to ask psychosocial and ICE, because this is the main reason, the agenda, why the patient came to see you today. How do you do that? For example, psychosocial or impact on life. You can ask the patient, Mr. Jack, I can see this has been happening for the last 3 months. How that has been affecting you? Or you may ask, has that been stopping you from doing anything you used to do at all? He may tell you, doctor, yes, I stopped going to work, it stopped me from doing that or that or that. So this is psychosocial or impact on life. When you think about impact on life, you think about work and home. Okay, for some cases, if it's a chronic problem or this symptom has been going on for a long time, that can affect the patient mental health. For example, if it's an acne case and a young lady has acne for maybe a few months, that can affect her self-esteem. How that has been affecting you, Amy? Doctor, it has been affecting my self-esteem. I have been feeling low because of that. If someone is mentally affected by their problem, you always need to screen for depression in that case. How to screen for depression? By 2 simple questions, which is the validated tool to screen for depression. Only 2 simple questions here. In the last months, have you been feeling low or depressed? This is the first one. So she already answered. She told you she's feeling low or she's feeling low self-esteem. The second question for the screening for depression: in the last months, have you been losing interest in things you used to do? If the patient answers yes to any of these 2, that's a positive screening for depression or for mental health, and then you can go ahead with that and you can do the mental health history. We'll do that later, yeah. But the patient will tell you likely that it's not affecting him in that bad way. And then the last thing in our data gathering in every single case will be ICE, idea, concern, expectation. Why you are asking ICE? As I mentioned, because the patient came because of that. How can you ask about ICE? Mr. Jack, have you given any thought what may be causing this headache for you? Idea. Concern, is there anything specific worrying you at all? Expectation, were you hoping for anything specific I may offer you today? Or have you given any thoughts? How can I help you today? So idea is different than concern, because this may confuse some people. I may think this cough is a chest infection, but in the back of my mind, I'm very worried if it's a lung cancer. This is the difference between idea and concern. Okay. Anyway, you always need to do it in a relevant way. And if you listen to the story carefully from the patient, you would already know what's in his mind. That will be data gathering, and data gathering should take maximum, for BLAP 2 people, should take maximum of 4 or 5 minutes in the worst case scenario. Do not exceed 5 minutes because that will affect your management part. Okay, to complete your data gathering, you would offer examination. What I would like to highlight here, that examination should be simple and relevant. What do I mean by that? Relevant mean you only examine what you are looking for. So do not ever mention I will examine from head to toe. That's very wrong. You do not say I will do general physical examination. Let me ask you why. What do you mean by head to toe? Does that include the small finger, the big finger, the back passage? Does it include the hair? Why you are doing that? We do not examine someone from head to toe. We examine what we are looking for because you have only 8 minutes or 10 minutes for the consultation, for example. So, Mr. Jack, I would like to examine you. That will include checking your blood pressure, your heart rate. I would like to examine your head and neck, and as well, I will look at the back of your eye. So that is a specific examination, for example, for migraine or for headache station. Or Amy, I would like to feel your tummy. I would like to examine your private area so I can know what is causing the bleeding for you. For example, you only mention what is specific to the case. And then, what do I mean by simple language? Do not use medical jargon. For example, if it is a vertigo station and you would like to do the Dix-Hallpike maneuver, do not tell the patient, Mr. Jack, I would like to examine you. I would like to do Dix-Hallpike for you. That will scare the patient because he doesn't know what is Dix-Hallpike. Okay, it may be something scary for him, which I believe it should, but you can explain it in a simple language. Mr. Jack, for us to help us with reaching a diagnosis, would like to examine your head and neck movement by a simple maneuver, which we call Dix-Hallpike. In that case, it will be relevant and simple, yeah. But do not just give the medical jargon. You need to explain that. Okay, that was data gathering. We finished that by 5 minutes. Now let's start our management. The management will start with our diagnosis. What do we need to know about diagnosis? 3 things. You need to be simple, so avoid any medical jargons. Don't try to be brilliant with medical terms. No, use simple language because this is your patient, not your colleague. Second thing, always engage the patient in your diagnosis. You can bring some of his thoughts or some of his words from the symptoms or history in here so you can show that you are listening to him. And the last thing in diagnosis, always check his understanding. So Mr. Jack, having listened to you and having examined you, I think the headache that you are describing is possibly a migraine. Do you know what is migraine, Mr. Jack? No, doctor. So migraine is a one-sided headache that takes you to bed. So that's an example. And then the rest of management will include investigations if needed. And what is the advice here? That please do not offer investigations if it is not needed. For example, if it's a migraine station, or if it's a depression, clinical depression case, or simple vertigo station, there is no need to investigate. This is what is mentioned in the guidelines. So when you offer routine investigations and it's not needed, you are wasting time. So you're wasting your precious time. Second thing, you're wasting resources. You're wasting NHS money. So you do not need to offer investigations if they are not helping you in your management. Yeah. Okay, and then you complete your management by offering the patient your lines of management and the options of management. Yeah, what should we know in this step? That you always need to make sure it's a shared management plan. So it should always be a patient-centered management. How we can do that? You can do that by offering the patient options, and as well by bringing what was his expectation to the management as well. Mr. Jack, I understand you were hoping for antibiotic for that. However, Mr. Jack, having listened to you, it looks more like a viral infection. Do you know what is the difference between the viral and the bacterial infection, Mr. Jack? Then you can explain and you can go ahead. Now you are bringing his expectation to your management and you are making it patient-centered. Yeah. And always make sure you check his understanding after you give a decent amount of information. Yeah. Second important thing in every management is addressing the patient agenda. So the patient will have some concerns, for example, doctor, why you do not do that? Why you're not referring me? Doctor, I would like to have a scan to my head. So this was concerns for the patient. This was requests from the patient, or the patient has some questions. So then you address them gently, and then you can see if there is anything in his lifestyle that you can change as well. For example, in most of GIT cases, if someone has IBS or indigestion, you can talk about lifestyle, that maybe changing your diet, making sure you do not drink a lot of coffee, alcohol, smoking, that can help improving your symptoms. Okay, or maybe, for example, someone had a TIA, you can advise, Mr. Jack, there are a few things you can consider changing in your lifestyle, which can significantly reduce your risk of having another blood clot, such as cutting down smoking. What do you think about that, Mr. Jack? Blah, blah, blah. And then the last 3 steps in every management is follow up. So arrange a decent follow-up for every case. So for example, if the patient is coming with depression, you can say, Mr. Jack, what do you think? Shall we catch up again in 2 weeks' time to see how are you coping with the medicines? And so arrange a follow-up and make it decent to the case. If it's a cold case, like for example, common cold, you do not need to arrange a specific follow-up, but you can be gentle and say, Amy, if things doesn't go right or you feel unwell, please call us back. We'll be happy to arrange another consultation. Yeah. So that would be very gentle. Yeah. Safety net the patient. And when you safety net the patient, you safety net the patient from the red flags. So what you asked here in the red flag, you can mention here as a safety net. For example, if it's a back pain station, your red flags will be coda equina symptoms. For example, any sudden loss of power of legs and any problem with controlling emotions or passing urine, this is your red flag. So then you can tell the patient, if your back pain gets worse or if you get any associated symptoms like problems with passing urine or passing motion or sudden weakness in your legs, please do seek immediate help or call 999. Okay, that's how to safety net. If it's a depression case, you would say to the patient, Mr. Jack, if you ever feel unsafe or you have any harmful thoughts in your mind, please seek immediate help by talking to crisis team, and then you can talk about crisis team. Give the patient a leaflet. In most cases, Mr. Jack will print a leaflet for you about that problem, so you can have a read about it. And if you get any questions or any concerns, please call back. We'll be happy to discuss. So this is the Masterkey structure. If you understand that structure, you can apply it in 99% of the cases. Yeah. We still have few more structures, but not for common use. For example, a structure for the breaking bad news, a structure for talking to angry patient or to talk to a medical colleague. We have a structure for counseling cases. It will be similar to that with few adjustments. If you would like to see them, just you can check the package. We have a package of all mind maps or all cases in mind maps. You are always very welcome to check that out, but everything will be following similar approach. So let's give you a few more lines which can help. Any children, you can still use perfectly the same structure. The only thing that you can add or you can change when you ask about the red flags here or the main differentials, you can always add a line to ask about feeding and dehydration, because that is very common things that we are worried about in most kids. If the kid is having a viral infection or any illness, we always need to make sure they are feeding well. So Amy, is it Charlie feeding okay? Yes, doctor. Is he breastfed or is he bottle fed? He's bottle fed, doctor. So you can explore that. How many times is he taking the feed? Or is it as usual? Yes, doctor. Is he passing urine and motion as usual? If it's a newborn child or a smaller child, does she have wet and dirty nappies as usual? Yes, doctor. Yeah. So if the patient is asking yes to these 2 or 3 questions, this child is likely to be well and surviving okay. So he will not need to rush or to do something that is very urgent today. In most cases, yeah. So that's a very golden line to ask about feeding, wee and boo, which is passing urine and passing motion, or wet and dirty nappies. Yeah. The second thing that you can try to change in the general structure, when you ask about lifestyle for a child, you wouldn't ask about smoking and alcohol. That would be irrelevant indeed, yeah. But you can ask about PERD, which is birth, immunization, Red Book, and development. I do not like asking about Red Book. It doesn't make any sense to me. But you can ask about how was the birth of the child? Was it a normal delivery or C-section? And is he up to date with immunizations? And are you happy with the child development? Yeah, that will be a good recap of the general well-being of the child. Yeah, psychosocial still can apply for the child, but when you think about psychosocial for a child, you are thinking about home and the nursery or home and the school, because the children will not be likely working indeed. Okay, so how that has been affecting James? So James may be having bedwetting or nocturnal enuresis that can be affecting him indeed. Yeah, this is what you do in this case. Yeah. So if it's a lady case or it's a female patient and it's a gynae case, what you can add here is actually asking the 4 P's of ladies, which is pregnancy, period, pill, and pap smear. So if the lady is coming with vaginal bleeding or discharge, I would ask her, when was your last menstrual period? Any chance you may be pregnant at all? And do you take any contraceptions? And are you up to date with your cervical smears? Yeah. So that would be 4 questions in gynae cases. Yeah. Not in every female, because if she's coming with common cold, you do not really need to ask about pap smear in common cold. So always be relevant at the end of the day. This is the last thing about the structure. So this is the Masterkey structure, which you can use in every single case. Yeah. Then let's move on. This is one case you can see in the playlist as well. We have followed the same structure. We have done it completely in another video. You can watch it in the channel. And the last thing before I finish, there is a mind map package, which includes all cases, more than 400 cases in similar mind maps to the one we have discussed. So in 5-10 minutes maximum, you have the whole medical problem with the whole guidelines about data gathering and management in a single mind map. The package includes other playlists as well, like IBS mechanics, management mechanics, cases simulation, SimMan teaching, examination, everything. Anyway, if you like to join, you are always welcome. Just contact me on that number on the WhatsApp or Telegram group, and you can join my groups as well from the description of that video. And I hope for you all the best. You should get 12 out of 12. Thank you, everyone.